Good afternoon, everyone. I'm Stephanie Maselli, Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us today for our webinar for the recently released report, Evidence-Based Practice for Public Health Emergency Preparedness and Response. You can download the report and the related resources at nationalacademies.org/PHEPR, or PEPPER for short, as we're saying. The slides and recording of this webinar will be available on that page as well, and you'll be directed there when you exit the webinar. For those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the entire committee and must undergo external peer review before they are released, as did this report. I have with me today several members of the committee to discuss the report, but before I introduce them, just a few reminders. This webinar is scheduled to last 1 hour. We'll start with a presentation summarizing the report by the committee members, and then we'll open it up to any questions you have. To submit a question, you can simply click the Q&A button on the bottom of your screen. And should you have any technical issues during this webinar, you can contact Zoom technical support at 1-888-799-9666 and select option 2. And with that, I'd like to introduce the members of the committee that wrote the report who are here with us today. We have our committee chair, Dr. Ned Kalanj from the Colorado Trust, Dr. David Abramson from the New York University School of Global Public Health, Dr. Francisco Garcia from the Pima County Department of Health, Dr. Paul Halverson from Indiana University, Dr. Suzette McKinney from the Illinois Medical District, and Dr. Paul Shakel from RAND Corporation. And with that, I'd like to turn it over to Dr. Kalanj.
Thanks so much, Stephanie. And welcome to everyone joining us on the webinar. I hope this is informative for you today. There we go. This is the committee's full membership with photos, as you see during our last Zoom meeting below. I just wanted to point out that it's a very comprehensive group of public health practitioners and other experts at all levels of public health, as well as academicians, public health emergency preparedness researchers, people who are experts at evidence-based medicine and evidence-based recommendations. It was a very inclusive and vibrant community of committee members, and the report reflects the expertise of all folks involved. We also had consultants to the committee to round out the kind of sense of representativeness of different levels and different types of health departments, and I wanted to make sure we recognized them as well. This study was commissioned by the Centers for Disease Control and Prevention. The kind of operating feeling was that even though we've had investments in research and we have a growing body of empirical literature, we really don't have a national level systematic review and grading process for practice, as we do in other parts of medicine and even other public health fields. We feel that this gives us the setting of having to relearn things over and over again, rather than implementing best practices and evidence-based practices, which we know would improve the health of our population. Our committee met 10 times over the course of 2.5 years, and you're seeing the results of our report today. This was a charge of the committee from the Centers for Disease Control, developed methodology for conducting a comprehensive review of evidence for public health emergency preparedness response, which I will call FEPPER from now on for brevity, and these practices, including the criteria by which to assess the strength of evidence, and a tiered grading scheme. Next, we were to develop and apply criteria to determine which FEPR capabilities should be prioritized for inclusion in the comprehensive review. Next, we should apply the committee's evidence review methodology to assess the effectiveness of these selected practices. Then we should develop recommendations for practices that communities, state, territorial, local, and/or tribal agencies should or should not adopt based on evidence. From now on, I will refer to these as public health agencies. Finally, we should provide recommendations for future research to address critical gaps, as well as processes needed to improve the overall quality of the evidence within the field. So starting with the first charge, developing and applying a FEPR evidence review and evaluation methodology, we created a multi-step mixed method review process, which I'm going to go over in some detail. The first step was to review the review topic, considering published literature on gaps and priorities and stakeholder input. I wanted to inform you that the criteria that we used to select these practices included relevance and importance to national health security, current needs as identified amongst key stakeholders, including practitioners and policymakers, our potential to actually impact FEPR practice, is make a recommendation that would be implemented. And then we also needed methodologic diversity so that we could create a methodology that could be employed across the 15 capabilities that are critical to public health, emergency preparedness, and response. These are the 4 topics we prioritized to discuss: engaging with and training community-based partners to improve the outcomes of at-risk populations after public health emergency, which is in the community preparedness capability. Next, activating a public health emergency operations center, which is in the EOC capability. Next, communicating public health alerts and guidance with technical audiences during a public health emergency in the information sharing capability. And finally, implementing quarantine to reduce or stop the spread of a contagious disease, which is in the non-pharmacologic interventions capability. We noticed earlier this year how each one of the 4 topics is important to our current response to the COVID pandemic, and appreciated that these were identified in working with our public health partners moving forward. At this point, we would need to review the relevant literature, have inclusion and exclusion criteria, and then start to extract the data according to an analytic framework that we would next develop. So that's the search, peer review, inclusion, exclusion. We actually at this point recognized we had different kinds of methodologic streams. So there's quantitative studies that include comparative, non-comparative, and modeling studies. And then there were descriptive studies, qualitative studies, after-action reports or AARs, and case reports. These are from where we extracted our data. The next step was to apply and adapt existing tools for quality assessment of each studies based on the study design. And all of this was done within the concept of an analytic framework, which created these key questions for us to review. As we moved on in the process, we then had to synthesize all of the evidence within these different methodologic streams and apply appropriate grading framework. So for the body of quantitative research, we used the international standard and recognized grade approach. And for qualitative studies, we used the extension grade CERQUAL. This allowed us to assess the certainty of evidence, or COE, for quantitative study, and our confidence in findings for qualitative studies. Next, we consider evidence of effect from other streams. Here we brought in modeling, mechanistic, qualitative evidence, AARs, and case reports, and looked for discordance or support for findings from the quantitative research studies. That allowed us to determine a final certainty of evidence. And then we would integrate the evidence from across the different streams to populate the FEPR evidence to decision framework to identify implementation considerations. We wanted to share the framework for integrating evidence to inform recommendation and guidance development for FEPR practices. Here you see two sides of the slide. The left-hand panel shows the committee's process for integrating evidence from quantitative impact studies with other evidence that would inform what works to help determine the certainty of evidence of effectiveness for any given outcome. The certainty of evidence for all relevant outcomes would then feed into the right-hand panel, which shows the pathway for integrating diverse evidence for various elements in an evidence to decision framework that, along with contextual considerations, inform the formulation of evidence-based practice recommendations as well as implementation guidelines. In cases where the review was focused on implementation and not determining effectiveness, it would be possible to follow the framework and depicted in the right-hand panel without assessing the certainty of evidence in the left-hand panel. The final step was to develop practice recommendations and/or implementation guidelines. So here we'd like to give you the results of the 4 pilot topics, starting with engaging with and training community-based partners. Included in this review, there was quantitative comparative and non-comparative, qualitative, case reports, surveys, and parallel evidence, where we looked at systematic reviews of evidence around engaging community-based partners, but from other disciplines other than emergency preparedness. The key findings from the review was that culturally tailored preparedness training programs for community-based partners and at-risk populations served improved the FEPR knowledge, that was with a moderate certainty of evidence, and improved preparedness behaviors, also with a moderate COE, of trained at-risk populations. This led to the practice recommendation that engaging and training CBPs serving at-risk populations is recommended as part of local public health agencies and other agencies' community preparedness efforts, so that those CBPs are better able to assist at-risk populations served in preparing for and recovering from public health emergencies. Recommended CBP training strategies include the use of materials, curricula, and training formats targeted and/or tailored to the individual CBPs and the at-risk populations they serve, and train-the-trainer approaches that utilize peer or other trusted trainers to train at-risk populations. The implementation guidance included ensure that multi-stakeholder collaborations within CBPs are diverse and inclusive, with particular attention to those groups that are often excluded and marginalized. Engage umbrella organizations such as the American Red Cross or United Way to reach smaller local community-based organizations. Consider participatory engagement strategies that allow for ongoing bidirectional communications with community-based partners to build trust and buy-in prior to an emergency. Tailor the curriculum and format of CBP preparedness training programs to the learning needs and preferences of specific audiences, and ensure that they are culturally sensitive and appropriate. And finally, consider soliciting stakeholder feedback in the evaluation of said training program materials and content. The next topic was activating an emergency operations center, where we included qualitative research, AARs, and case reports. Here we had an insufficient evidence finding that although activating a public health emergency operations center is a common and standard practice, which is supported by national and international guidance and based on earlier social sciences around disaster response, there is insufficient evidence to determine whether activating an EOC and what specific components are or are not effective at improving response. Now, this does not mean the practice does not work. It does not mean it should not be implemented. It does indicate that more research and monitoring and evaluation around how and in what circumstances an EOC should be implemented are warranted before an evidence-based practice recommendation can be made. However, if you remember the right side of the framework, we are able to use evidence to provide implementation guidance. And so there we had considerations for when to activate a public health emergency operations center, and they included the emergency is large in size and complex in scope, or when a novel response may require multiple new tasks or partnerships, or the event occurs that requires public health support functions, large-scale information sharing, or response coordination. When resource, cost, technologic, legal, and logistical constraints need to be overcome, or an incident requires high levels of interagency partnership. And all of these considerations may attend the same emergency. You may also consider when to refrain from activating a public health EOC, such as when the cost of activating is higher than any potential resource needs for the emergency. And finally, considerations for how to make the decision to activate public health EOCs included respecting staff knowledge and involving staff who have had past emergency experience in the leadership discussions. The next topic was communicating alerts and guidance with technical audiences. Included evidence types, included quantitative comparative and qualitative studies, surveys, after action reports, and case reports. The key findings were that electronic messaging systems are effective channels for increasing technical audiences' awareness of public health alerts and guidance during a public health emergency. We had a moderate certainty of evidence here. Different technologies have differing impacts. However, data are insufficient to conclude what technology is best for which audiences and which scenarios. So the recommendation was inclusion of electronic messaging channels, such as email, is recommended as part of public health agencies' multi-pronged approach for communicating public health alerts and guidance to technical audiences in preparation for and in response to public health emergencies. The practice should be accompanied by targeted monitoring and evaluation, or conducted in the context of research when feasible, so as to improve the evidence base for strategies used to communicate public health alerts and guidance to technical audiences. Turning to implementation guidance, we suggested you engage technical audiences in the development of communication plans, protocols, and channels. It's important to reduce message volume when feasible and highlight new information and any differences from previous or other existing guidance, so that the impact is always the same and uniform. You should develop distribution lists in advance of public health emergencies and ensure that the contact information is kept up to date, and consider designating liaisons and institutional points of contact. Also leverage existing networks such as medical societies and associations, which can help facilitate broad message dissemination. The last topic was quarantine. And here we included quantitative, comparative, and non-comparative studies, modeling and qualitative studies, case reports, surveys, and mechanistic evidence. The key findings with there is a high certainty that quarantine can be effective in certain circumstances. But the evidence also points to substantial undesirable effects and harms, including increased risk of infection in congregate quarantine settings with a high certainty, psychological harms with a moderate certainty of evidence, and individual financial hardship with a high COE. Frequent and transparent risk communication, messaging, and access to employment leave may improve adherence to quarantine, found with a moderate certainty of evidence. That led to a practice recommendation. Implementation of quarantine by public health agencies is recommended to reduce disease transmission and associated morbidity and mortality during an outbreak, but only after consideration of the best available science regarding the characteristics of the disease, the expected balance of benefits and harms, and the feasibility of implementation. Turning to implementation guidance, when to implement quarantine should be early in the outbreak, especially when there is a shortage or absence of available medical countermeasures, only after weighing the resources required against the expected benefits. When the R naught, or reproductive number, is in a range which quarantine can be expected to importantly reduce transmission. Quarantine for durations should be commensurate with the expected duration of asymptomatic infectiousness that needs to be feasible, and there needs to be an absence of or short asymptomatic infectious periods. How to implement quarantine: should consider voluntary before legally enforced quarantine, avoid congregate quarantine, consider the at-risk populations, protection of civil rights, and protection from avoidable harms. Considerations for during and after the implementation include providing clear messages on the rationale for quarantine and the financial, compensation, food, social, and psychological support necessary to keep quarantine feasible and minimize harms. As we are looking at the evidence, I will tell you that we needed to get a feeling for the broader state of evidence across FEPR and the different capabilities. And we commissioned a report reviewing and creating these evidence maps for quantitative US impact studies. So I know this is a slide that's hard to read on a smaller screen, but across the top are the 15 FEPR capabilities, and across down the side are the outcomes that were considered in the scoping review. There are multiple dots of different shapes and colors that you'll see that correspond to the study design and whether or not it was an individual or system or organizational level study. I think the takeaway for us was how many cells there are in the table that are empty from quantitative impact studies. This joined with our examination of the evidence available to us in our 4 pilot topics led us to the conclusion that the science underlying the nation's response to public health emergencies is seriously deficient, hampering the nation's ability to respond to emergencies most effectively in order to save lives and preserve well-being. So I'm going to end with talking about recommendations to improve and expand the evidence base for public health emergency preparedness. The first recommendation is to appoint a FEPR evidence-based guidelines group. CDC should appoint and support an independent group to develop methodologically rigorous and transparent evidence-based guidelines for FEPR practices. This needs to occur on an ongoing basis. The group should take the methodology developed by this committee as a starting point, but should also be charged with its continued evolution and development and improvement. The group should also identify and communicate key FEPR evidence gaps in annual reports to CDC and to Congress to guide further research on the effectiveness of FEPR practices. The second recommendation is to establish infrastructure to support ongoing FEPR evidence reviews. CDC should establish the infrastructure, policies, and procedures needed to ensure a sustained process for conducting and updating evidence reviews and for generating evidence-based practice guidelines. It should be done in collaboration with other relevant federal agencies, and the infrastructure should include an open access repository for evidence-based FEPR practices. The third recommendation is to develop a national FEPR science framework. To enhance and expand the evidence base for FEPR practices and translation of the science to the practice community, CDC should work with other relevant funding agencies, public health agencies, academic researchers, professional associations, and other stakeholders to develop a national FEPR science framework so as to ensure resourcing, coordination, monitoring, and execution of public and private sector FEPR research. You'll see a diagram of kind of a starting point or of the framework that includes concepts of building on and improving coordination, integration, and alignment among existing FEPR research efforts. Also ensure integration with the activities of the FEPR evidence-based guidelines group proposed in recommendation 1. It includes recognizing and supporting FEPR science as a unique academic discipline. It should include creation of a common, robust, forward-looking FEPR research agenda, support meaningful partnerships between FEPR practitioners and researchers, and prioritize strategies and mechanisms for the translation, dissemination, and implementation of FEPR research. And in the middle of this diagram, this framework, is an acknowledgement that there needs to be system leadership to transform how research is coordinated, funded, and conducted. That leads us to recommendation 4, to ensure this infrastructure and funding to support FEPR research. CDC, in collaboration with other relevant funding agencies, should ensure adequate and sustained oversight, coordination, and funding to support a national FEPR science framework, and to further develop the infrastructure necessary to support more efficient production of better quality FEPR research. Such infrastructure should include sustained funding for practice-based and investigator-driven research, support for partnerships with academic institutions, hospital systems, and public health agencies, the development of a rapid research funding mechanism and interdisciplinary rapid response teams, and an enhanced mechanisms to enable routine, standardized, efficient data collection with minimal disruption to delivery of services, such as pre-approved adaptable research and IRB protocols, and a research arm within the response structure. I believe in the current COVID environment, had we had these last 2 bullet points in place, we could have been generating new knowledge and new information to populate recommendations from the beginning of the pandemic that we could now use later as we continue to face the issues. Recommendation 5 is to improve the conduct and reporting of FEPR research. CDC, the Office of the Assistant Secretary for Preparedness and Response, or ASPR, the National Institutes of Health, the Department of Homeland Security, the National Science Foundation, other relevant FEPR research funders should use funding requirements to drive needed improvements in the conduct and reporting of research on the effectiveness and implementation of FEPR practices. These efforts should include developing guidance on and incorporating into funding decisions the use of the appropriate research methods so that the questions being studied and the methods being used are better aligned. Should include establishing guidelines for evaluation, using different designs, different evidence streams, and concepts from emerging evaluation approaches, such as complex intervention evaluations, and should include developing reporting guidelines, including essential reporting elements in partnership with professional associations, journal editors, researchers, and methodologists. Recommendation 6, we should pursue efforts to further a process of quality improvement to enhance the quality and utility of after-action reports. This is a recommendation specific to a type of evidence that is ubiquitous in public health and in public health emergency preparedness, to look back and learn from our performance in response to a given event. CDC, in collaboration with ASPR and FEMA, should convene an expert panel of relevant federal agencies, public health agencies, and professional associations to advance a process for quality improvement at the local, regional, state, and national level, to enhance the quality and utility of AARs, and to support their use as sources of evidence for evaluating the effectiveness of FEPR practices. This process should foster a culture of improvement in public health emergency response and should include, but not be limited to, discussions aimed at defining the essential core elements of the FEPR AAR, establishing an independent review panel with a standardized after-action reporting process, establish and maintain a national repository of AARs, and explore privacy issues and the protection of information in AARs from use in legal proceedings or in other punitive actions. I have 2 more recommendations. Recommendation 7 is to support workforce capacity development and technical assistant programs for FEPR researchers and practitioners. CDC and ASPR should work with professional and academic organizations that represent multiple disciplines to guide and support the creation of the workforce capacity development and technical assistant programs necessary to ensure the conduct of quality FEPA research and evaluation and improve the implementation capacity of public health agencies. These efforts should include developing a research training infrastructure and career development grants, providing training grants for FEPA researcher and practitioner teams so they can work together, provide ongoing technical assistance and peer review networking for both FEPA researchers and practitioners, and create a training and certification program for CDC project officers and state preparedness directors. And our final recommendation is kind of where the rubber hits the road. Ensure that the translation, dissemination, and implementation of FEPA research to practice. CDC should use a coordinated implementation science approach to ensure that evidence-based practice recommendations resulting from the FEPA evidence-based guidelines group proposed in recommendation 1 achieve broad reach and become the standard of practice of the target audience. Strategies to this end include incorporating evidence-based practices into the public health emergency preparedness and response capabilities guidance document, building evidence-based practices into the design of and funding decisions for the public health emergency preparedness cooperative agreement at CDC, incentivizing and requiring public health agencies to test and evaluate new or adapted practices and embed evaluations into routine operations, disseminating evidence-based practices via CDC communication platforms, such as the MMWR, as well as those of partnering organizations, ASTHO, which is the Association of State and Territorial Health Officers, and NACHO, which is National Association of City County Health Officers. Finally, consider leveraging the Public Health Accreditation Board accreditation system and NACHO's Project Public Health Ready platforms to help assure this translation and implementation. I will conclude with a couple of thoughts. The release of this report in the context of COVID-19 puts the challenges of a limited research base to support evidence-based FEPA practices in bold relief. Our recommendations around adequate, stable funding, robust design and conduct of research studies, development of a research workforce and programs, and commitment to collaboration between public health practitioners and experienced researchers are all vital to ongoing support of the knowledge development for and implementation of interventions that will better protect the public's health and minimize the impact of the broad spectrum of emergencies that have and will certainly continue to threaten the security of our nation. I want to end by thanking you for attending the webinar and with special thanks to our two study co-directors without whom this report would not have been possible. There are also your contacts for further information regarding the study and the report itself. This concludes the presentation, and I would like to turn control back over to Stephanie, who will help facilitate the question and answer session of the webinar.
Thank you all. As a reminder, if you are planning to submit a question, you can do so at the bottom of your screen in that Q&A chat box. And if you're so inclined, feel free to identify yourself and your organization when asking a question. The first question for our panel is, why is this report recommending the creation of a national FEPA science framework?
Suzette McKinney, I wonder if you would address that question for us.
Sure. Thank you, Ned. I'd be happy to address that. One of the things that our committee recognized throughout the course of our study, we really felt strongly that a national framework would be needed to establish the goals and objectives to improve public health emergency preparedness and response, the research coordination and alignment with research across the public health preparedness and response practice community, as well as funding organizations such as CDC and ASPR, as well as professional associations and other stakeholders. In doing our work, what we found was that the evidence base for public health, emergency preparedness, and response was not comprehensive. We really saw a series of one-off studies. Many of the studies that we were able to identify and review in the course of our work was limited by one topic or one specific disaster, or perhaps one specific agency conducting research, rather than a progression of research or a more comprehensive approach to that research across jurisdictions, across disaster events, or across agencies. The other thing we've seen are challenges related to conducting research in the midst of an emergency. And so we thought that having a national science framework would really enable CDC and its partners to ensure that a research infrastructure is in place prior to an emergency response. Many of the audience members might remember during the Ebola outbreak, as well as a Superstorm Sandy, how several of our federal government partners really worked diligently to stand up a research framework, but it was really in the midst of those disasters. So one of the goals of a national preparedness and response science framework is to have that infrastructure in place prior to a disaster. And then I think as we learn more about public health emergencies, dealing with each of the emergencies that we've seen over the last few years, we recognized as a committee that there is a need to establish a mechanism for collecting new evidence, but also even conducting research in real time. And without a system to support that research coordination and ongoing evaluation of evidence, we felt that it wouldn't be very effective for emergency preparedness and response practitioners to continue to implement practices that we haven't had the opportunity to validate through research. Thanks, Ned.
Thanks, Suzette.
Our next question is something that's on a lot of folks' mind. How can public health officials at all levels apply these recommendations to the ongoing COVID-19 pandemic?
I wonder if I could direct that question first to Francisco Garcia and then to Paul Halverson.
Thanks, Ed. That's an easy question to field. The real crisis that we are living in as public health practitioners today really amplifies the need for a system that allows us to do these things that we all expect should be having a positive impact in a systematic way and in a way that we can continue to evaluate. And I think that that's one of the lessons here. The timing is serendipitous, right? Or tragic, however you want to think about it. But what Suzette spoke about, which is the need to systematically review what we're doing and make decisions, not just for today, for the way that we manage this particular crisis in Pima County, over the next couple of weeks, but really for how we take these lessons and we learn into the future. I think that's where the real opportunity is. And I think that public health practitioners really are at a loss in the fact that we are trying to put our finger on what we think is a very leaky dike rather than dealing with some of the larger issues. And we really need that larger national comprehensive framework and infrastructure to allow us to do something systemic.
I mean, let me just build on Dr. Garcia's comments, which I thought were excellent. I certainly agree with them. In some ways also, we're experiencing another dilemma, which is that we are, as a public health organization or enterprise at the state, federal, and local level, at a time of very substantially reduced budgets. This is sort of a pattern, if you will, for public health funding. We respond to an emergency, and when the emergency is off, we sort of go back to doing our own business, if you will. And so at a time when we really need to rise to the occasion, we've seen great work at state and local, federal level, but it is of a high variation because of the fact we don't have strong evidence base to suggest those processes which really are the most effective. We really then look to following patterns of what we've done in the past, rather than really sharpening our focus on those things that are most effective. And so in some ways, thinking through the evidence base and creating a much more narrow window of interventions which we know based upon the evidence will work, that would allow us actually to be much more efficient, cost efficient in what we're doing, rather than simply trying a lot of different ways without a strong evidence base. And so we find ourselves in the midst of COVID doing what we've always done, looking to evidence from the CDC and from direction from our state health departments, when in fact, many of those organizations also lack the evidence base upon which to make these important practice-based decisions. So having strong evidence to support the selection of interventions that work for us every day would allow us to be much more efficient and effective. And the other thing which I think it would be important, which we don't talk about frequently, is the importance of interoperability. If we had a common language and we knew the most effective strategies to employ, then I think we would do that on a more consistent basis, and we'd be able to compare our results between states and among local municipalities so that we could know where we need to make improvements. So I think overall, as Ned, as you've said, the issue here is that when we were establishing this work a couple of years ago, we had no idea COVID was coming, but in actuality, it brings in pretty clear relief the importance of this work for moving forward.
Thank you. Our next question is, racial and ethnic minority groups tend to be more vulnerable to disasters, and they may distrust government messaging and preparedness programs. What can be done to ensure marginalized communities are not left behind? And another attendee asks, what do culturally tailored preparedness programs look like? Do you have any examples?
So I'd like to pick on our FEPA researcher, if I can, to get his thoughts in terms of answering that question. David Abramson.
Thanks, Ned. One of the cases that we looked at was precisely how to engage community-based partners in achieving preparedness outcomes or system-level outcomes. And what we found that there was a certain amount of literature. We found some moderate certainty of evidence that by engaging these community-based organizations to act as essentially brokers by which communities can have bilateral communication with their public health officials, with their public health agencies, so that there would be essentially a trusted agent operating to help those who have the least amount of political voice, perhaps have the greatest amount of interaction with their public health agencies. I think it's also worth noting that when we looked at this literature, we found that there was evidence of an effect, but the effect was to some extent a little bit limited. It affected the increase in knowledge and an increase in protective actions or behaviors. But it doesn't get to the core question, how do you improve the ultimate outcomes? How do you improve mortality, morbidity? How do you improve equity and effectiveness? How do you improve the cost effectiveness of these things? And looking at this through an equity lens kind of demands a larger systematic perspective. So this is good. It's good to see that there's evidence to the effect that having community-based partners engaged in this kind of work will help people in the community, whether they're racial, ethnic minorities, cultural minorities, underserved populations, increase their knowledge and behavior related to protective actions, but there clearly needs to be the next big step to say, okay, and does it also help improve their health, their well-being, the resilience, et cetera, in the community?
Thanks, David. Go ahead, Stephanie.
Thank you. From the committee's experience, can you offer any lessons learned in how to work across different disciplinary and methodological silos?
Yeah, Dr. Shikal, as one of our key methodologists who had to actually broaden your view and your perspective, I wonder if you would be willing to answer that question.
Oh boy, that's a hard one. You know, as we talked about, one of the important things in this particular field is the different ways that we can know something might work, and so it can span from tightly controlled experimental studies to naturalistic experiments to modeling studies to qualitative studies, and in the kinds of systematic reviews that have been done in a number of other disciplines, a lot of these other kinds of things aren't really considered very much. And it really focuses pretty much on the hypothesis testing studies. And so it was a challenge because I don't think there's any single person or even 2 or 3 people that are the repositories of knowing how to do things across all these different areas. And so we needed to bring in both methodologic experts, but then also people that have helped generate some of the research in each of these different schemes. And there is no existing recipe for how to put them all together, how to break down all the information from those different silos into a single synthetic result. And so we sort of did our own, and we did the best we could, and we think it's pretty good. And but I'm sure that as we go forward, we'll find out ways to do it even better.
Thanks for handling the hard question, Paul. I think diversity was very important, I think, in trying to be comprehensive. And we did have some learnings even along the way saying, oh, you know, I wonder if we shouldn't engage somebody with additional expertise in qualitative data synthesis, which, you know, since I would suggest that we were heavy on the quantitative side, having that viewpoint opened up a whole new area of evidence streams that we had to understand and incorporate to make the best recommendations we could. And so we did learn and benefited from diversity as we moved forward. Stephanie, back to you.
Thank you. The next question is, understanding that the heart of this report is a systematic review, does it address some of the upstream forces that prevent public health departments from doing many things which we already knew were important to do? For example, engaging community-based partners.
Francisco, I'd like to go back to you on this one. If you could unmute, sorry.
It's a tough question. I can think of a multitude of upstream factors that really impact outcomes, that impact health outcomes every day, and are perhaps even more dramatic and more salient in the middle of a disaster. Katrina and Maria didn't happen that long ago, and certainly the lived experience of COVID in Chicago versus in Arizona really sort of highlights some of those upstream factors that have to do with accessibility, with racism and equity issues and access to care. I think that what this report does is it says these things are important as part of a larger framework, and it allows you to think operationally about how you start taking into account those considerations as you think about critical communications with technical audiences, as you think about engaging your stakeholders, as you think about doing all the different components of the response, the quarantine, for example. And so from that standpoint, I think this is foundational. And though it certainly doesn't address from soup to nuts the issue of the upstream issues, I do think it provides a platform to begin to systematically deal with some of these structural issues.
Thanks. Stephanie?
Thank you. There are a number of research methods in the FEPR field. They range from exploratory case studies to randomized controlled trials. How can practitioners determine what method is most appropriate for answering research questions of interest?
Yeah, I think this is an answer that I think I might ask a couple of folks to chime in on. I might start with Paul Schickel and then also make sure that David Abramson or anyone else who wants to chime in. But those two folks, if you could just think about your answers. And Paul, is it okay if I start with you?
I have a choice on this? Yeah, anyway, you know, it is a great question because I think there is what's the right word, a danger or a perception that everything has to be a randomized trial in order for it to be accepted. And if there's anything that, or if one of the things that we helped contribute to in this report is that that's just not the case. There's a lot of different ways to try to generate evidence that can be used to try to understand how something works. But in general, if an intervention can be tightly defined, then and you have the ethical ability to randomize, then yeah, that's a great way to do it. All right, and which is why pharmaceuticals are so often studied in randomized trials. The intervention is manufactured to a very tight tolerance, and then you can randomize people to either take it or not take it. But that's not going to happen a lot in public health preparedness research, and so a lot of this is going to be naturalistic experiments. And there are ways to make them more stronger methodologically that just looking at, you know, bringing in a methodologist to try to help you understand how to take what's in front of you and turn it into the strongest possible way to draw an inference would be the way forward. Because I don't think that there's a single cookbook that says, if you're doing this, then do this. If you got that, then you do something else. Each one's going to have to be a case-by-case kind of thing.
So Ned, you want me to jump in on that one?
I would like you to, David. Thank you.
Because I'd like to say that the two critical words that every good researcher would answer when posed that question is, it depends. It depends on what you're trying to answer, the kind of resources that you have available to you, the type of data that you might be able to gather. Sometimes there's great administrative data that you have easily available, and you could use that instead of having to gather research data. So, you know, once you start thinking about mounting a large research operation to answer a question, you may want to consider reaching out to your academic partners, finding your local school of public health, finding the local university, seeing if there are academic partners that can help you think through the ways to reduce bias, because that's ultimately what you're going to try and do, reduce bias so you have the clearest answer that links X to Y, whatever that X to Y would be, from intervention to outcome or to administrative practice to a process outcome. So it depends.
Ned, could I just add a couple of things to this if I could?
Please, Paul.
So I really I think both of the answers were great, but I also believe it's important to sort of recognize at the on the ground level that in the midst of a disaster, most of us aren't thinking about how are we going to evaluate this and how do we report it. The focus is really on implementing the best solution, if you will. So that's why this report was so important, because it establishes a national framework and creates ahead of time the framework by which we do the research and report the research. And then most importantly, it's the idea of thinking through how do we systematically implement those things that have the best likelihood of success. And the last part is to suggest that the time to set up the infrastructure for research and emergencies is far before the emergencies. It's not in the midst of it, but actually pre-positioning and creating the opportunity to take advantage of those emergencies that come up. So I think that was one of the real important parts of this framework and the solution essentially that the committee recommended.
Thanks, Paul.
Our next question is, has there been discussion about modifying the Homeland Security Exercise and Evaluation Program framework to perhaps better align or better fit the FEPR capabilities? Currently, it is geared toward FEMA core capabilities. An exercise and evaluation framework specific to FEPR might provide standardized data for research purposes.
Back to Paul Halverson. Do you feel you could comment on this from the Homeland Security standpoint?
Well, I'll take a shot at it, Ned. Again, not having current knowledge of our FEMA colleagues, but I do know that one of the things that we have done in public health emergency preparedness is to merge the interests of FEMA and public health and try to do both planning and joint exercises. And I think there's a high level of receptivity. I was at a meeting within the last 6 months that brought together emergency management and public health people together to try to talk through the issues around how we can plan and exercise together and improve our overall response. And so I do think there is an opportunity and an interest in terms of bringing these things together. The important thing is to do it prospectively and to recognize that sometimes emergency management wants and needs certain things out of an exercise that may be a little bit different from public health. But again, with proper planning, I believe that you can actually check all the boxes for both public health and emergency response by appropriately setting this up, again, in advance, thinking through the research that needs to be done and those capabilities that you want to try to demonstrate. Remember, one of the recommendations also in implementation was looking at creating a certification for both our public health technical advisors as well as our state emergency preparedness response coordinators. The idea here was to begin to create a sense of uniformity around the interventions that might be recommended. And that same approach could be taken perhaps working with FEMA to design exercises and evaluation frameworks that could serve both purposes. And so I do think there's a lot of potential for synergy in that regard.
Thanks, Paul. Stephanie, do we have time for one last question?
We do, and that would be, what does future workforce capacity and preparedness look like? Can you outline those recommendations?
So I'm going to return to pick on Suzette around workforce. She straddles very different workforce entities, and how you thought about this with your public health or your direct healthcare services, if you have some ideas to provide.
Sure. Well, I think, Ned, in response to the question, there's certainly been a long-standing understanding that our public health workforce is aging, and the need to augment our public health workforce, but specifically our public health emergency preparedness and response workforce. I think in terms of moving into the future and trying to augment that workforce, there needs to be more concentrated partnerships between public health agencies and schools of public health within their jurisdictions to ensure that courses are being taught in public health emergency preparedness and response, and as much as possible, actual public health emergency preparedness practitioners, if not teaching those courses, are at least brought in as guest lecturers, I should say. But I think also within public health agencies opportunities to cross-train their existing public health staff to be able to achieve greater public health emergency preparedness and response capability is also a way to augment our public health workforce, and is certainly something that I've done in my experience, not just in public health, but as an emergency preparedness and response practitioner.
Thanks, Suzette. And the only thing I would like to add is, remember in the framework, there's this piece about recognizing that FEPA research is a unique discipline. And so beyond the workforce of practitioners, thinking about adequately training, recognizing, and funding with sustained funding and partnership opportunities, an active and nimble public health emergency preparedness research workforce is a key recommendation. And I think those two pieces, what Suzette brought to the table and what we think about for research as well, are essential to improving the evidence base. Stephanie, I'll turn this back over to you.
Great. And it looks like that is all the time we have for questions today, and we had a few hundred people join, so I apologize if we didn't get to everyone. But once you exit this webinar, you'll be redirected to our report page where all the materials are, and the contact information is if you have follow-up questions. Once again, I'd like to thank our speakers, and thank you all again for joining us this afternoon.
Thank you.